At the outset, I'm grateful to AIOS and the AIOS Scientific Committee and the chairman for inviting me for this prestigious webinar. And I've been enjoying all the excellent lectures so far, and will continue to enjoy them. I'll quickly share my screen. Uh, all right. I was asked to speak on intumescent cataracts. It's mostly going to be video based, and we all are dealing with this. All of us, I think, and most cataract surgeons actually have this challenge of the intumescent cataract. So the challenges with the intumescent cataract could be many. At the outset, shallow AC, high intralentricular pressure. They could be upthrust sometimes in these cases, especially glaucoma patients as well. Runaway rhexis is always a risk that you're always scared of. So you're trying to make sure that you don't have one. Sometimes you can have the rhexis redundant tag prolapse through the incision, and that can be a challenge. And with the escaping viscoelastic, they can be a flag sign. So several, innovations have been made, or whatever. I mean, people have gone through the, so many ways of managing these intumescent cataracts. We use ample use of viscoelastic, of the correct viscoelastic, the soft shell technique, yagging the anterior capsule. I was listening to this yesterday in one of the webinars. I added it here. I personally don't do that. Decompressing the lens, which I think many of us are doing now in different ways. A small quick rhexis followed by aspirating a little bit and then enlarging the rhexis. Pancho-rhexis as popularized by Dr. Mohan, but much before that, even by Uday Devgan and so many others. Spiral rhexis, which again is a wonderful technique, and I'll be showing one of those. Zepto can be used, and even the femto-assisted, which has probably become a very popular way of managing intumescent for those who actually own one. So these are so many ways that we can tackle it. I wanted to start by this one video. As you can see, I do use a rhexis marker, and then I stain it with the trypan blue. Now here we were managing an intumescent. We didn't anticipate that this would cause problems in our estimation. So we are going with the conventional way of doing our rhexis. Otherwise, I would normally follow a different way. But you can see that suddenly now there is this beginning of an extension. So I quickly go from the side port, try to aspirate, but just watch what happens. And this is the reason why I wanted to show this video. Sometimes if you're trying to decompress, if you suddenly aspirate, it can catch the capsule and the rhexis tear can actually extend. So this can cause problems, and then you can of course try to manage it, but if it runs away completely, then you're in a soup. So when using all these aspiration techniques for decompressing the lens, one has to be very careful that use a very fine cannula and make sure that you don't get caught with the capsule doesn't get caught or sudden decompression doesn't happen. Now another situation where we are dealing with the intumescent cataract, and this didn't appear again to be a problem, but as we reach near the main port, and you can see here that suddenly the viscoelastic escapes and the flap tends to come out. And I'm sure some of us have held this problem, and it can be dangerous because it can cause a runaway of the rhexis. So at this point, you have to be very, very careful. You can manage this redundant flap carefully, push it back, or you can snip it if you have some kind of good scissors which can go through and put in more viscoelastic to let it go back. Sometimes putting in viscoelastic can be counterintuitive because it can actually bring the flap further out. So you have to be very, very careful that you don't let this run away. And then once you manage it, of course, you can go back and finish the rhexis, and it's not difficult to manage, but this does require care. And now, in spite of all these things, when you have an intumescent cataract, sometimes, you are fearing that the moment your rhexis is, you're fearing that it can go into a flag sign, which sometimes it does in spite of all your best efforts. And then, you have to kind of make sure that you manage it adequately. And one way which I talked about initially, and which is one of my favorites as well, is to, of course, you can aspirate and do that, but a spiral rhexis, making a smaller rhexis first, and then this is a slightly fast forward video, so please excuse that it looks fast, but you have to do it very carefully and gently and slowly. And you can first make a slightly smaller rhexis like that, and then you can go and actually, once you've completed one round of the rhexis, a small one, a frill of rhexis can be, you can keep doing it and it'll never run away. So this is one thing I've learned over the so many years that I've been doing these patients, that even pediatric cataract with intumescent lenses, if you have that small frill, it is never going to run away, and you can take 3, 4, 5 rounds, as many as you want. So you can see here that I've almost completed maybe 2 or 3 rounds, and yet it has given me the adequate size rhexis. So what I currently do is this, stain the capsule, put viscoelastic. I try to use Viscoat because it works well for me. I've done the soft shell and everything else. Dr. Arshinov is here and we'll take his comments on that. But once I've done that, you'll notice that I'm not going through the main port, but I'm going through a separate new paracentesis to decompress the lens. And let me just show you how it works. So we will stain it, and once we've stained it, we will, make sure that we have adequate viscoelastic there, and you can see that this is an intumescent brown cataract. Now, making sure that all ports are sealed. So my side ports, my main port, everything is sealed so that the chamber cannot be lost. So I'm taking a 26 or a 30 gauge needle from the new port. There is no chance of decompression or leakage. Yeah, I'm sorry. I'm sorry. I'm sorry. Yeah. So I'm just decompressing and aspirating. Now you can either go bevel down or bevel up as is your comfort, but you have to be sure that you don't catch the capsule, and do it gently. And once you've decompressed the lens, you can obviously complete the rexus very easily. And this is what I prefer to do today. But let me show you the challenges with this as well. And here again, we are doing this decompression and aspirating, and you can see that it aspiration worked. Then I thought that it needs a little more decompression, went in from the side port and did a little more, making sure that viscoelastic is replaced each time. And then you can do a quick small rexus, because here I felt that, the mid periphery was still intumescent enough that I was worried that it might run out. So here again, I went with the spiral technique, and believe me, this really works well. So all those who are listening in, whenever you're in a situation like this, make a small rexus, and then, you can make a bigger one. And if it just completes as a small rexus, don't hesitate to give a small snip on it, and then make it larger, make it adequate. Because see, this is a brown cataract. If you have a small rexus to deal with, you're going to have problems cracking the nucleus. So please don't settle for a small rexus. If it completes accidentally, then please go around and snip it and then make a bigger rexus, and it works quite well. Now, sometimes these things don't work, and you can see here that there is a situation where this was a very intumescent cataract. We went in with the technique that I prefer to use now, and I aspirated. I'm so sorry. Yeah, in spite of all the experience with the webinars, I'm still making these mistakes. Um, so here it aspirated a little bit, decompressed, but see what happened the moment I went in. Now you can see that, I'm just entering to inject visco, and this has started running away. So even the slightest decompression can cause problems, and you have to be very, very careful that the chamber remains stable at all times. And then, I'm just using the cannula to just reflect that small flap, and then of course you can complete it. So these are the situations, but now just watch what happens. I was very nice and happy after giving one oration on intumescent cataracts. I thought I've achieved it all. And I said in that oration that in 300 cataracts now with this technique, I've never had a flag sign. And when I came back first OT, I had this patient, just watch what happens. I have done everything right so far. And I'm going in to, make the decompression. And once I, manage to go in, just watch, I'm in now. And I'm just going to start aspirating. And as I start aspirating, I just touch the lens there. Just watch. I just touch it. And before even I have time to do anything, so sometimes if you've done everything right, in spite of that, sometimes this will happen. Now, what is the key? The key is to do an OCT pre-op. I now have started doing OCT for all my intumescent cataracts. And if you see these clear fluid spaces just behind the capsule, you have to be fully prepared. Second thing you should be looking at is the AC depth and the lens thickness. So if you can look at this, if you have an AD of like less than 2 millimeters, you have to be extremely careful. You can look at the convexity of the lens, and you can look at the lens thickness. If it's more than 5.5, these are situations. So today I do femto-assisted surgery. I'll just show you quickly, and then we'll finish. Once you do this, yeah, I'll just finish in 30 seconds. I won't show you details of the surgery. So all I wanted to show was that in a femto, which is currently my favorite technique for those who have access to a femto, it is very good to be able to do this. And you can pick up the intumescent cataracts, you can pick up the AC depth, and then you can, still get away with a good surgery. You can see that, just watch the mushroom as the laser fires, you'll be able to appreciate what happens in an intumescent, just see how that explosion takes place. And yes, I would like to just point out, I'll conclude that femto is not fail-proof. I still manage to occasionally get tags in the end of the surgery. And I also manage to get sometimes a broken rexus, but the percentages are really, really small. So the take-home message is that please, if you have access to an OCT, please do an AS OCT. Please make sure that you're watching the AC depth and ensuring that the convexity of the lens is under watch. Use viscoelastics correctly. Make sure that your chamber remains stable all the time. Decompress the lens from a separate port, rather not from the main port or the side port. Have good control, good instruments, good micro-rexus forceps, go only from the side port. And if possible, if you have access to a femto or something, that would be a great idea as well. Thank you so much.